Good morning to one and all. On behalf of IAP Digital team, I, Dr. Rutra Mohan, welcome you to this webinar on clinical gait analysis to improve patient outcomes by resource person Dr. Bhupinder Singh. This webinar is being streamed live on IAP India YouTube channel. I request all to subscribe to this channel to view our live webinars and receive regular notifications. To know about our upcoming webinars and events, you can check the social media channels for the IAP pages on Facebook, Instagram, Twitter, LinkedIn. This webinar is being organized by IAP Women's Cell Maharashtra State Team. The moderators for today are Dr. Nirali Sanghavi, Dr. Snehal Patel, and Dr. Priya Karande. I request the moderators to please take over.
Nirali, check your mic.
Hello, good morning, one and all. I hope I'm audible to all of you all. Yeah, I would briefly like to take the opportunity to introduce IAPWC. IAPWC functions under the guidance of National Head Dr. Ruchi Vashne and IAP President Dr. Sanjeev Jha. We have 5 zones in India with heads for each. Dr. Pooja Kamble is the West Zone head. The state team of IAPWC Maharashtra includes State Coordinator Dr. Suvarna Ganveer, Joint Coordinator Dr. Snehal Patel, and Sub-Coordinators Dr. Utra Mohan, Dr. Priya Karande, and myself, Dr. Nirali Sanghavi. In Maharashtra, we have conducted over 40 plus low-cost activities like CMEs, workshops, public awareness campaigns, health camps in various districts since 2018. We have also organized 50 plus webinars in the past 9 months. And now, since past 1 month, we've also started few field activities like visiting the orphanage and even training for the sports people. In the first corporate IAP conference held in 2019, Maharashtra state received award for the best state IAPWC. We are constantly working towards expanding the scope of activities and workshops for the benefit of our profession. To know more about the events, kindly follow IAPWC Facebook page and IAPWC YouTube channel. Here, I'm privileged to introduce briefly Dr. Bhupinder Singh, who is a resource person for us today on the topic of clinical gait analysis to improve patient outcomes. Sir is an associate professor with California State University. Dr. Bhupinder Singh is a licensed physical therapist and associate professor at California State University. He completed his BPT in India before joining the prestigious PhD program in Carver Medical School at University of Iowa in USA. He is currently the director of Gait Analysis Moment Evaluation Lab and teaches in the core content areas of orthopedics, exercise physiology, and evidence-based practice in Doctor of Physical Therapy program at California State University. He also runs a pro bono amputee clinic to serve the undeserved population of amputees in California. He also specializes in NPTE preparation for foreign trained students and is the owner and founder of NPTE Final Frontier Teaching and Research Institute. Thanks a lot, sir, for giving us the opportunity to have you with us on this platform. Over to you, sir.
Thank you so much, Dr. Nirali and Dr. Snehal Patel, for having me here, and thank you everyone at IAP and at your institution to organize this event. I'm going to start on time and share the screen, and this is what I will be covering today. And the topic of my talk is clinical gait analysis to improve patient outcomes. And we'll look forward to making it an interactive session, and hopefully we'll have some interaction, even though it's a webinar, but I'm hoping there will be some interaction at the end with some questions. So I will go ahead and get started. Thank you, Dr. Nirali, for a wonderful introduction. And as she said, I am BPT from India, and it's such a pleasure to come back after many years in the IAP circles and present on a topic which I've been studying and researching and teaching for more than 10 years in the United States. So just a quick overview of the profile in case you want to reach out to me or contact me for any of these roles. I did my PhD in physical therapy and rehabilitation. During those times, they allowed BPT from India to directly go into a PhD program with a funded scholarship, and I was lucky to get it. It was one of the number 5 ranked universities in the United States. I've been teaching in the DPT program for about 8 years now as a full-time professor, and I've gone through the tenure process, and I am the director of the Gait analysis lab here. So if anyone is interested in clicking on the link and the information to know more about gait analysis, we have a lot of resources on this link. And I've been working as a licensed physical therapist, also running a pro bono clinic, as well as a lot of us from India have trouble knowing how to come to United States and what are the processes. So we founded a nonprofit few years back. It is called as Foreign Academic Credentialing Tools and Services, as factsforpts.org. And I'm the serving board president since the inauguration of this nonprofit. And as a side job, which has become into a teaching institute and a research institute over the last 6-7 years, I'm the owner of NPT Final Frontier. So this is for anyone who's trying to come to US and Canada and work as a licensed physical therapist. So I am Indian and Desi at heart. You can see I look Indian, and I will remain loyal to the community who first ignited the fire to become a physical therapist for me. So anyone who needs to reach out to me, feel free to use any of these links to contact me. They have all of my contact informations. For topic of today is going to be about 40-45 minutes of discussion on clinical gait analysis. That is a specialty area. And when you think about clinical gait analysis, we think of it as very simple task, which can become very complicated if the patient is not doing it properly. So when I think about gait, I have given you 2 images here, and I will be writing a little bit or like pointing my cursor a little bit to the left side first. The left side is showing all the muscles which get involved in just taking a step. So for example, I want to start walking and I'm going to take one left step. Look at all the muscles which are needed for that just one simple step. And we take about 6,000 to 10,000 steps every day. So all the muscles at the bottom, the gastrocnemius, you can call it the plantar flexors, dorsiflexors, the hamstrings, the hip extensors, even the spine muscles are going to be activated for that one simple task of taking a step. On the other hand, you can also see that clinical gait analysis can be as fancy as looking at, for example, a Disney or an animation movie. So they can always, the patients can always be converted into almost like a skeleton or an animation movie. And then we can look at their joints, we can look at their stresses, we can look at some of their kinematics, we call it, the range of motion, or kinetics, which is their biomechanics in terms of their stresses and torques at each joint. So my job today is going to give you a little bit of a flavor of how the technical world works in gait analysis, but I also understand that majority of our audience is going to be practicing in India as BPT or MPT, and some of your interns from your final rotation or final clinical internship you're doing. So I'll try to also tell you how to use some of these sophisticated gait analysis tools in your outpatient clinic or in your hospital setting. So first thing you're going to be looking at is what are the phases of the gait cycle. So I would have loved to have all of you here and we could have gone through it in person and everyone could have walked and tried different gait patterns. But given we don't have it, I thought I'll make myself, I'll make one arm as my floor and then the other hand can act as my foot. So to just show you an example of what gait looks like, gait is going to be usually, it starts with initial contact. So when I'm walking, you hit the ground and that's called initial contact. Then you're going to go into a loading response, which means now you're putting force on that foot. After that, you go into mid stance, And from mid stance onwards, you're going to finish the terminal stance, which means these 4 steps, the initial contact, the loading response, then middle of the stance, which is called mid stance, and terminal stance are going to be when your foot is in touch with the ground. When your foot leaves the ground, that is going to be starting as a swing phase, and you will go into pre-swing first, getting ready for the swing phase. Then you'll go into initial swing, which, as the name suggests, is the initial part of the swing phase. Then we'll go into mid-swing, which is the middle of the swing phase, and then we'll finish with terminal swing. So it is just like you're hitting the ground, you're completing your stance phase, and then you're coming back again and hitting the ground again, which means you've finished one full gait cycle. In most of the clinics, you might also use the term heel strike instead of initial contact, and that's okay. So heel strike, foot flat, and toe off are also going to be the 3 phases of the stance phase listed here. In order to make it clinically relevant for our patients or our physical therapists or physiotherapists to understand, I have divided in my mind the functional task and gait phases into 3 different tasks. So what is the body wanting to do when it is trying to walk in a normal pattern? So the first one is called weight acceptance. Weight acceptance, again, remember, you are landing, and when you land on the ground, you're going to be doing the initial contact, and then immediately you're going to do the loading response. So the first task of weight acceptance will be finished in initial contact and loading response. The second task will be finished, is called single leg support. That means only one leg is in touch with the ground and the other leg is up in the air. So we're going to call it as mid stance and terminal stance. And the third one is called limb advancement. This means now the limb has to move forward. So obviously we are going to talk about the swing phase. So if you are looking at clinical outcomes, sometimes you can always think of the stance phase, which means the foot is in touch with the ground, or swing phase. But to make it a little bit more refined, you can always subdivide it into the sub phases of gait, which are the 8 sub phases, but divided into 3 different tasks. There are some definitions I will clarify first. They will be repeat almost of what I just said, but anyone who's taking notes. So gait is just a manner of walking. Gait cycle is when you start with one limb, just I was showing with my hand. So I start with my right foot, hitting the ground. I complete the gait cycle, and then afterwards again, I hit again with the right foot. That means that's one gait cycle. You can also call one gait cycle as one stride, S-T-R-I-D. And then when I talk about steps, I have a right step and a left step. When I take both steps, if I take a right step and I take a left step, that will make a step length, and 2 step lengths will get me 1 stride length. So any questions you might have, you can just put them in your chat. I have it on the screen. I can always clarify any things as we go along. So when we look at gait pattern, we're going to start looking at it in the clinical world. So here's a picture from one of my clinics, and it is just showing a normal student or a patient walking on a mat, and this is called the gait right mat or the gait mat. And you're looking at the same thing I described in text. So they are going to have a step length, which means that red dot which just showed up. From the red to the green, that's going to be a step length on one side of the foot. And then if I take another step, then I have completed 1 stride. So if you look at the color coding, red to red is going to be 1 step stride length. And then you can have your step length as your the red to the green. Now let's talk about what we can do, because everyone may or may not have a gait lab or a gait mat in their clinics. So the rule I follow from many years to analyze the gait is I like to be about 4 steps behind the patient. So if they're walking in front of me, I need to capture their frontal plane, which means their posterior side or anterior side. So when I say frontal plane, I'm You're looking at my face, that's my front. And I also captured them from the side angle, which means sagittal plane. So I'm going in this direction. So that's going to be called as the sagittal plane. So for proper gait analysis, with the naked eye also, without any machines, you can capture a lot of things in the frontal plane, in the pelvis area or the trunk area, and you can also capture a lot of things in the side view. So in the next few minutes, I'm going to take 3 case scenarios or 3 case examples where we can dissect a little bit more on how these are going to be helpful for our clinical studies. Okay, so let's look at what is the specialty gait analysis, which would be used as a gold standard. So here's a picture of my gait analysis lab, and it's called GAME lab. So GAMES is just a full form for gait analysis movement evaluation. So here what we do, on the right side of the screen, you can see this subject or the patient standing, and we're putting markers on their body. So what are these markers? These are basically infrared light emitting diodes, we call them. And what they do is when the patient comes in the clinic or in the hospital or in the lab, we can put these markers on each of their body segment. So in this image on the left side, you can see this patient is having their markers put on her foot, her knee, her pelvis, her trunk, and even in the front. Those markers, if I put 3 of those markers on one of the areas, so if I put 3 on the shoe or 3 on the knee, that will help me generate that part of the skeleton model. And then this person is going to walk anywhere in that lab, and they're going to be in a 3D environment, 3-dimensional, just like animation movies are made. And whenever they move, we're going to be capturing up to 60 to 100 images per second in our camera systems. It's hard to see in the image, but just between her legs right here, there's a circle. That's going to be one of the camera systems, which is capturing those images. And then 9 cameras are going to combine together and make me a skeleton model of that patient. So technically, if you're looking at it, I put the irids, which are gray in color, and then I move them, right? So they are going to be given, or they're going to look like a skeleton model. And then that person is going to be walking in that 3-dimensional space, and I can watch them walk. They can do running, they can do jumping, they can do any performance they want. If they say I have pain in certain areas, I can ask them to do it, and then I'll be able to see their gait as they do that motion. So that is called clinical gait analysis in a gait lab. And the first step I showed you, the step length and the stride length, that's going to be more in the outpatient world. So given all the attendees here, if you have to understand gait in a more layman term, as we call it, I recommend you and I imagining that you are sitting on a chair. Okay, so all of you are probably sitting or laying down. I know it's Sunday morning in India. So think about, I'm sitting on this chair and I'm relaxing. Okay, and it's called a rocking chair. So if I rock back too much, if I go back too much, what will happen? The chair will rebound and ask me to come forward. So gait is also kind of used like that. You can think of gait just like that, that when you go too much backwards, even if you're sitting or standing, if you want to try it, if you go on your heels, which means the back part of your foot, and you lean backwards, which muscles are going to help you come forward? So the muscles which are going to be interior in front of your body. So if you try doing it, the muscles which are in the front of your body are going to say, okay, come forward. Okay, those muscles are going to be your dorsiflexors. Those muscles are going to be your, like, think of all the way muscles up, right? They're quadriceps, they're abdominal muscles, they're trunk muscles. So when I come forward, so I was almost falling down. If my muscles did not help me, I would have just fallen down like this. But my interior muscles helped me and they brought me up forward. And now I'm too much forward. So now I am on the other side of the chair, this side. So at this forward position, now I am on my toes. So what's going to happen? My toes are going to say we're going to fall on my face. So now my posterior muscles are going to fire, which is my gastrocnemius soleus muscle or my hamstring muscle or my gluteus maximus muscle. They're going to fire and they're going to take me to the next level. That is called as a rocking function of gait. So if you read some of the gait textbooks by established authors, or if you look at it in detail, this is called a rocking function of gait, where you're on the heel first, then your interior muscles work, and you go onto the ankle and then to the foot, and then your posterior muscles work, and that cycle repeats again and again. That's why you and I, we don't get tired. We walk normally. It's like an everyday habit, because it's like a pendulum or a pendular motion which has developed for your gait analysis or for your gait normal everyday activities you do. So think about the chair. Think about a rocking chair like it's bouncing, and think about how we have anterior muscles working at that heel strike and posterior muscles working at that toe off or at push off time of the gait. Now let's expand on it a little bit, and let's think about how you can learn the analysis part of your patient outcomes. So I'm going to expect all of you to think about gait as a problem, a solution, and a phase. What does that mean? Anytime a patient comes in, you can ask me any examples of any gait analysis patient in the chat. So let's say there's a patient with cerebrovascular accident or stroke, or there's a patient who's having problems with cerebral palsy, or there's a patient who is having total knee replacement or total hip replacement. So anytime we have to deal clinically, we think of the muscle or the problem as the first thing. We're going to address that. Then we look at how we will address it. So what is the solution? And then we look at which phase of the gait cycle that problem and that solution is going to work, because not every time the solution is going to work in throughout the gait cycle. Remember, we talked about weight acceptance, which is initial contact or loading response. Maybe the problem is in that. Maybe the problem is during limb advancement, which is the swing phase. Maybe they're not able to clear the ground. So we have to count on three things: problem, solution, and phase. So for today, for about remaining half an hour, what I thought I would do is give you our experiences as three common gait abnormalities, which are listed here, and then use our analysis by functional significance model to answer those common gait deviations. Not only, okay, this is the problem, but also tell you what is the solution and why that is the solution. So the first one we're going to go over is trunk bending deviations. Then we'll go to leg length discrepancy, and then we'll go to inadequate muscle control deviations. Depending on time, I might be able to add one slide on amputations at the end, and we will then wrap up with questions, of course, at the end. So let's start with trunk bending. First, I want you to familiarize yourself with your planes. What is the frontal plane? What is the sagittal plane? And then what is the horizontal or transverse plane? So frontal plane is you're walking and watching your patient from the front or their back. Sagittal, again, remember, side. And transverse or horizontal is, let's say you don't like what I'm saying and you cut me in half, and then you look at from top of my head on how my hip is moving, the rotation wise, like this. So that is called my transverse or horizontal plane. The first tip I can give you is always treat your plane. What does that mean? If the problem is in the frontal plane, so think about frontal plane, right? You all did it in your internship or BPT or MPT. In the frontal plane, you look at the abductors or the adductors. So like abductor muscle like gluteus medius or adductor magnus. So if I am having a problem in the frontal plane, I should try to treat that plane first. So if the problem is with the pelvis drop is not going to be seen very well in the side view. It's going to be seen in the front view. So I should treat the muscles which are in the frontal plane, which means abductors and adductors. But let's say if I have a patient who's having hyperextension or problem at the knee joint, I may not be able to see it very well from the front plane. I will have to walk them sideways. Then I will be able to see the knee hyperextension. And then I can say, okay, let's treat the sagittal plane, which means let's work on the flexors or extensors. Okay. So thank you, Kiran. It's sticking to your plane is what we're doing. Now we will go to the next step of using this information. And I have put a slide together showing different causes of a lateral trunk lean. So let's say the patient comes in and they're leaning to one side, left or right side. We now have to find out why are they leaning to a specific side. So if my hip abductor muscles, like my gluteus medius, is weak, then I'm going to be leaning towards the same side of that weakness. If I am having problems with a contracture, or if I have a short limb, or sometimes we see patient with stroke, they have an impaired body image. They don't know where the center is. So they sometimes might lean to one side more than the other. So let's take an example. Let's say this is a patient who came to the clinic, and we know that we have to use problem and solution model. So just by basic analysis, what we can see here is this person is running or walking on the treadmill. And if you look at her top or her t-shirt, it's showing that the pelvis is leaning a little bit towards the left side. It's almost like it's dropping on the left side. So as a clinician or as a physiotherapist, I should first write down what is the problem. So my problem is I have weak hip abductor muscles, which are causing pelvis drop on the left side. Now, what should be my solution? From first year of BPT, we learned that if a muscle is weak, you strengthen it. So I will strengthen the muscle, which means I'll strengthen the right hip abductors. Now the challenging part comes on how will I strengthen the muscle. So most of the times we see that strengthening of the muscle is done by, you say the patient should lay down on sideline and then they will lift their leg up and keep it at 30 or 40 degrees of hip abduction. But a more effective way of strengthening those hip abductor muscles is to have the patient actually do it in standing. So you tell them to stand on the same right leg, and then they're going to move their left leg away from the right leg. That is going to be an example. This is a case scenario 1, where problem and solution were combined to get the better outcome of the patient. But the exercise was done by having them standing on that right leg and doing the left hip abduction. Why did we do that? So if you want to become a very good physiotherapist or a clinician, always think of why. Don't think of I said it or a professor said it or a book said it. In your mind, think of why did we do that? Why did we have the patient do the motion in standing? And then you can say, I want to stick to my plane, right? If the patient was dropping their pelvis, I was looking at the frontal plane, so I want to strengthen the frontal plane muscles. Or you can say, closed chain is better than open chain, which means if they're standing on that leg, maybe that is more helpful for their rehabilitation, because that will treat them in a more functional way, in a more closed chain way, because that's how they're going to use it. So in case you do see patients, which is very common with our sedentary lifestyle, patients do not exercise their frontal plane or abductor muscles, and they end up having that pelvis drop. So to treat those patients, think about problem, solution, how to treat them, and also why to treat them. So if you have any questions on this, feel free to type in the chat. I can answer it as we go along, or we can always have our panelist at the end gather all of them together and I can answer them also at the end. So first case scenario I want you to think about is the problem and solution for the hip abductor muscles. Okay, let's try one other question or one other scenario. So what about other trunk leans, right? So patient is leaning to the lateral side. I told you that it's weak gluteus medius muscle or tight adductor muscle. How about when patient leans to the back? So you see this a lot in patients who are sitting on their chair for a long period of time, right? So patients in India where they have a sedentary job, where they're going to be in a grocery store or a Karyana store, or they are in a car selling factory where they have to sit, that's their job, or in banks when they're a cashier. So when they keep sitting for long periods of time, over a few years, their gluteus maximus muscle, which is your big hip extensor, that starts to become weak. So if you see them walking, they will be a little bit obese because of that sedentary habits, but they will be walking with a backward lean. It's almost like they're struggling to stay upright. Backward lean happens because of hip extensor weakness, gluteus maximus weakness. And sometimes you will see patients walking with a forward trunk lean. So forward trunk lean means they're going to be having weakness of the interior muscles. And in Indian terminology, we sometimes call it the hands to the knee gait, right? Where the patient is so weak in their quadriceps that they cannot extend their knee. So they're leaning forward to reach down to their knees, and then they're like pushing them with their hands to make sure they can walk. So lateral lean is when the muscles are weak on the lateral side. Backward lean is when the muscles are weak on the posterior or the backward side. And forward lean is when the muscles are weak on the front side. An easy example to remember. So for example, this is a water bottle, okay? And I take a magnet. So water bottle is my trunk here, like my upper body trunk, and my magnet is my weak muscle. So weak muscles act as a magnet. So if I have a muscle which is weak, let's say I have the trunk straight and my muscle is weak on the lateral side, like gluteus medius. So the muscle is going to say, trunk, I'm weak, and the trunk goes and gets attached to that muscle. The muscle doesn't go towards that because it's already inserted, right? It can't change. So as a magnet, the trunk goes laterally. If I'm walking this way, this is my trunk going away. This is my gluteus maximus. Gluteus maximus says I'm weak. Trunk says, okay, I'll come and help you. If I'm walking forward, which means my quadriceps are weak, then my trunk is going to lean forward. So always think of the muscles as weak muscles. As magnets, they're attracting your trunk towards them. Okay. There are a couple of questions in the chat. I can quickly answer them. So one question is, how do phase and deviations relate to the swing phase? So to answer those, this is for the stance phase and it switches in the swing phase. So if my hip extensors were weak and I was leaning backward in the stance phase, then in the swing phase, I will probably try to do the opposite. So that's how you can switch it from stance to swing. Okay, let's take another scenario. So we covered the case of backward lean, forward lean, and lateral lean. Now we can spend some time on leg length discrepancy, which is very commonly seen in our patient populations. And I can first show you what I mean when I say leg length discrepancy. Most of the times, there will be problems with plantar flexion issues, especially the plantar flexion will be too much. Now, what's the most common neuro patient we see? Okay, so in India, most of our neurological populations will be stroke, right? Cerebrovascular accident, or some of you might have seen patients with cerebral palsy. Okay, so patient comes in and their foot is dragging on the ground. Patient with cerebral palsy comes in, they don't even have a heel contact. They are literally on their toes all time long. So what is happening if you are having those patients? There will be three compensations or deviations you're likely to see. And I have listed them as pictures also I created for you on the slide here. So one, they're always on their toes. Two, they could lock their knee or cause hyperextension. Three, they will have a forward trunk lean. So imagine a CVA stroke patient walking when you do the home visit or when you see them in your patient clinic. They're going to have either all three of them or at least one of them. That is going to be understood best if you think of someone wearing high heels. Okay, let's say I had a patient and they were wearing high heels on both sides. Okay, and then one they took off. So now how are they going to walk? One side they're wearing the heels, let's say the left side. Now on the right side, they're going to have to plantar flex more to touch the ground. So when they plantar flex more to touch the ground, all of these deviations are going to come. If you ask any female executive or physiotherapist who wears high heels, even for a few hours, they will always say, I tend to lock my knee in hyperextension. And they will never say, they will always say, my back hurts at the end of the day. And they will never say, I lean backwards. They will always, if you watch them walking, they will be leaning forward. And the reason is, again, same thing. They are in plantar flexion. Too much plantar flexion, the knee is going to go lock itself into hyperextension and the trunk is going to come forward. So that's a good example of how you can remember your excessive plantar flexion patients. Let's take an example with this one too. And you can do some special tests, obviously, to confirm it, right? So for now, we have talked about two cases. One, we talked about that frontal plane, gluteus medius weakness, and that is called the Trendelenburg gait, where you will have pelvis drop on one side and trunk lean on the other side. And the second, we're talking about the muscles in the front, which are probably causing either a trunk lean or a backward trunk lean or a lateral trunk lean. So these are the two tests which probably we do in the clinic. We strengthen the gluteus medius, and then I am going to use an example of the Thomas test. Thomas test is going to check the flexibility of the hip flexors. So second case study coming up is going to be called as phase and solution. So the first one was, I know the problem, I just need a solution. This one, I know the problem, I know the solution, but I first need to decide which phase of the gait cycle is affected. So this is one of your images from the textbook. You can see the top patient laying down and the bottom picture showing that their hip is going into flexion. The white arrow is showing the difference. So Thomas test is positive, which means their hip flexors are going to be tight. So when my hip flexors are tight, what will happen? They will try to make sure if I'm walking, right? So if I am in a standing position, let's say so this is my patient. So this is their femur and the hip joint, this is their knee joint, this is their ankle, right? So patient's hip flexors are tight. So now if I try to take a step and try to go into terminal swing, which means I'm in hip extension and I want to leave the ground, my tight hip flexors are like, no, we can't go into hip extension because we don't want to stretch. We are very tight. So the subphase of the gait cycle, which will likely show that limitation, will be terminal stance. So if you see a patient and they come in and they are struggling with extension of the hip in the terminal stance, you can be the cool physiotherapist and you say, okay, I think I see something is tight. Come lay on the bed. Let me quickly do a Thomas test. See, Thomas test shows that you have tight hip flexor. And to treat you, so now we're going to the solution, you treat them by either stretching their muscles, which are tight, or you can strengthen their hip extensors. So either way, you're combining your information you learned about the trunk lean and your information about the muscle asymmetry, and then you can treat them by stretching or strengthening. Stretch the flexors because they're tight, and strengthen the hip extensors because they're weak. There is the concept of lower cross syndrome, as discussed in many classes you have taken. They will be talking about lower cross means if there's an anterior pelvic tilt, the muscles of abdominal muscles and your gluteus maximus are weak, whereas the hip flexors at the back extensors are tight. Think of any politician, any cop or policeman at a higher rank. They have this big, huge belly, and their pelvis is always interiorly pelvic tilted. That means their abdominals are weak and they're not controlling their pelvis. It's going down into an interior pelvic tilt. Okay, so this is my case scenario 2. If you have any questions, feel free to ask now or at the end. We have one more to cover. And the third one is going to be talking about the muscle action. This is just for your notes. If anyone of you is learning still Gait or still doing exams and classes in your masters, the best way to remember the muscle activity is first remember what the muscle group is, then remember when they're working concentric and when they're working eccentric. So this is just a follow-up slide if you want to remember the function of the quadriceps or the hamstrings. Now, how do I look at the muscles below? So we're talking about the hip and the knee, right? Quadriceps and the hamstrings. So the third one is going to be inadequate muscle control. So what happens if my muscles are not controlling properly? So for this one, I chose a case study of a patient, and I will need some help from you now, right? You have understood the teaching style. We have a problem. What is the problem? I know you don't have to type in the chat, but think yourself. What is the problem shown? The problem is the patient is walking, and look at their right leg here. I'm pointing my arrow. Their heel is being lifted off the ground, which means their gastrocnemius muscle is doing an early heel off. So again, patient comes to your clinic, you don't need a fancy gait analysis lab, or you don't need markers and skeleton models. You are seeing this with your eyes, right? Previous question, they were not going into full hip extension, and you're like, okay, Thomas test. This third case scenario, they are not going in a proper heel off. Their heel is coming off earlier than usual. It's almost like the gastrocnemius is saying, I am too tight. I am not able to fully control this motion, and I'm going to leave the ground earlier than usual, which means a right early heel off is going to mean that their gastrocnemius or the gastrocnemius muscle is tight. So what would you do? Look at the problem, tight gastrocnemius. Look at the solution. What is the solution? You stretch it. So basically, same story repeated again in a different clinical patient. Patient said, tight gastrocnemius muscle, you treat them by strengthening or stretching it. You can stretch it against your passive resistance by a PT. You can have them stand in front of a wall, lean forward into the wall, and basically do dorsiflexion, which will stretch their gastrocnemius. So that will start improving your clinical outcomes, because now you're not depending on the doctor or the physician to tell you, do the ultrasound or do the TENS and treat this patient. You can now use your clinical judgment and say, I see you walking and you are having this early heel off, and I will stretch your gastrocnemius or give you a stretching program you can do at home, and they will actually help you get better on that. So that's going to be your third case scenario. If there are any questions on it, feel free to ask or add. I see a couple of chat messages coming through, and that's really helpful feedback. If you have any doubts, I can clarify as we go along. Okay, so I think the last topic I want to cover is, again, muscles. Some of you might be thinking about what's the best way to remember the muscles. If you're talking to your patients, use the rocking chair example, explain them how interior muscles bring them forward and posterior muscles lift them off the ground in toe off. So for example, this is a slide with the ankle muscles. So we have pretibial muscles, which is the tibialis anterior, extensor digitorum longus, extensor hallucis longus, and they work eccentrically when you're lowering the foot to the ground, which means you're landing and then you just slap your foot. As you might have heard, foot slap or toe slap, you're basically not able to control. So if you're not able to control eccentric contraction, then that means you're going to have weak anterior tibial or tibialis anterior muscle. If you think about their concentric, so think about our stroke patients again, they're walking and it's time to go to the swing phase, but they have a foot drop. So they're dragging their foot on the ground. They can't clear it, which means at that point, I need a concentric contraction. I need a contraction which will clear my toes off the ground. So that will be called as concentric contraction of the pretibial muscles. So knowing the function and knowing when they would work is very, very important for these patients. We already did the example of the calf muscles, the gastrocnemius, the soleus, and we know that when I'm landing with that foot flat, they work eccentrically to slow me down, but their bigger function is to do heel off during the concentric contraction, which is going to be the ankle plantar flexion. So I need to leave the ground. I'm doing the toe off, as you saw in the previous picture. So that's when my calf muscle will need to activate. All right, so looking at what other clinical populations you can use clinical gait analysis, we are starting to see a trend for a lot of amputations in our Indian populations or everywhere, right? Bad air pollution, diabetes is one cause, and obviously injury during trauma or traffic accidents. If you have to deal with a prosthetic device, a prosthetic device is basically an artificial limb they're putting if someone has lost their natural muscular limb. You can see the same gait deviations in those patients. So we have a few minutes left. Think about, look at this patient. What do we see? What's going on? So this patient name is Jim. He's one of our clients and he's walking, right? And I actually have his prosthetic device here too. So this is his prosthetic device he's wearing in that picture. So this is going to be same story, right? A lot of you see a lateral trunk lean. So what did we decide? Lateral trunk lean happens because of muscles which are weak on the lateral side, which means gluteus medius is weak. But in this patient, the gluteus medius is not there because it was cut. It is under his shorts. It's all the way up to his hip. So this is the artificial socket they have developed, and it's hollow because his leg will go inside here, right? And this wall they created, they made it a little bit lower by mistake. So now he thinks that he's supported on the lateral side, but when he steps on it, he's going to lean because he thinks that's a weak side of his prosthetic leg. So same way you can use, even if you get a prosthetic device patient in your clinic, you don't have to be nervous and worried about like, oh, this is an artificial limb. You can just say, let's check the symmetry of your prosthetic leg, and let's look at what we can do both in terms of muscle and the prosthetic device to make it stronger. So you can use the terminology. If the muscles are weak, they will lean to that side, but if the walls are lower, they will lean to the same side. Same way, in his case also, the medial wall, the medial side is a little bit too tight or too long. So that means a wall which is too long is going to act as tight muscles. So anytime you see a patient, even if they are a prosthetic device patient, you always look at their deviation on anatomical causes, which is like weak abductors or weak muscles. And you look at the prosthetic causes, which is the short prosthesis, or as you say, the wall was too low or inadequate. So I just leave this table with you as an example. This is from your O'Sullivan book, the red color book we use in most colleges in India now, Physical Rehabilitation by O'Sullivan. And this, you can read more about it from that table, but I kind of summarize the three things we talked here: lateral trunk lean, abduction, and lumbar lordosis based on that Thomas test, which was positive. Okay, any questions so far? There's one more I see. Okay, most of you responding very well in the chat. Thank you for attending on a Sunday. And I think I'll conclude. I know there were a few questions I tried to answer in between, but if there is any other questions you might have, feel free to reach out. I'm presenting here more as an Indian who've been raised by IAP, or I can say raised by the Indian education system. And we have a lot of team members in the United States. Vrunda Kapadia is one of a very dear colleague. She, I think, presented in this panel a few weeks back or a few days back. And then I took help from some of the friends or colleagues who work as licensed PTs here in United States, like Priyam Sanghvi, who's a DPT now, Rahul Shah, Akansha, and Neeraj Tankari. I think a couple of them are attending here, so thanks for supporting. If you do have any questions for anyone who is attending, feel free to just let me know if there are any ways we can help you to welcome you to this awesome profession. I visit India every year. I teach a course to the American students, taking them to different parts of Indian hospital system, showing how we were raised. Like this, we did ultrasound and we did shortwave diathermies too, right? So showing them how the patients, how 60, 50 patients are treating in one day in a hospital system or in an outpatient clinic. So because of COVID, I'm not visiting, but I'm pretty easily accessible if you want to ask any questions while I'm in the United States. So here's a quick picture of our team. Some of the faces might be familiar to the attendees. And I think I'll just conclude with this slide and pass it back to our panelists. Thank you for joining everyone today.
Thank you, sir. It's a very informative session. There are some questions which is there
Yes.
on the chat box.
Sure.
Is the gait is important for the PCE in Canada? Someone asked.
Yes, so the Canadian physical therapists also do gait analysis, and they need a proper gait analysis in terms of examination and differential diagnosis also. So it's a very important topic for the Canadian physiotherapist also.
Okay. Can you throw some light on the robotic gait training machines?
Yes, great question. We have two different types of robotic training. One is we are using simulation, which means, for example, I was showing an example of how the patient could be put in a marker system. So we can do a robotic simulation on them, which means we can see, let's say a surgeon says this patient has cerebral palsy and we'll have to cut the tendons or cut their muscles and lengthen it. We can simulate it and say, if you cut the tendon by this many inches, the patient is going to start walking like this. So we can use overskeleton models to do some robotic training, but there's also a new field developing where the robotics can be used, basically replacing the world of physiotherapists. They're not needing us. They want the robotics or the automated machines to help, but there's not a lot of research on it, but I'll be happy to send more information if anyone needs on that area.
Okay, sir. Next is post-percutaneous myofascial release procedure done. When can we start the gait training of the child?
A good question. I actually have a similar patient. I think it's going to depend on the doctor or the surgeon also on how much time they give, but usually 3 weeks to 6 weeks, which is about almost 1.5 months, is a safe margin to assume if the doctor allows you to do it. And it also depends on the age of the patient, because like my patient is about 9 years age. So if they're much younger, then you might have to adjust with their parents and their doctor schedule.
Okay, thank you, sir. So I think one question is related to the, can we start directly apply to US or Canada exam with BPT degree from India? It's
yeah, I think I saw Mosam Shah, you're asking it. Yes. Yeah. So if you, I think the first thing I will recommend you to do is don't just come to United States or Canada just because you need to work as a PT, plan it a little bit. Both countries will accept your bachelor's in physical therapy, and you will have to do credential evaluation. So you can visit any of our websites. I gave you the link of the nonprofit. We can guide you at no cost on the steps. I also have a flow chart for what are the 9 steps for the Canadian exam. So first you have to apply for evaluation, and it takes a little bit for them to collect your DMCs or degrees from your Indian college, and then they finalize it and they let you know if you're eligible. But both countries accept BPT. United States needs a little bit more on the courses. They need some courses which are not taught in India in BPT. For example, physics and chemistry is done in our +2 or 10th +2 or 12th standard, and it is done here in the college, like in their PT degree. So that is not counted for Indians in America. So sometimes we have to take physics or chemistry again at a level of the physiotherapy college or online to get it approved. But both countries allow BPT, so you don't need to do a master's. But if you're looking at higher education, like I did, or like a lot of my team members or colleagues did, you can always think of going to one of these countries as a student on a master's degree. And while you are there, you can convert your degree to get eligible for those countries and pass their licensing exam and then start working. Once you pass the exam, you can convert your visa to a work visa from a student visa.
Okay. Thank you, sir. So these are the main questions, and it's already your answers in between the sessions. Now I would like to Dr. Priya to take the vote of thanks.
Thank you so much, Dr. Bhupinder Singh, sir. I myself, Dr. Priya, would like to take the privilege to express my gratitude. It was very informative and a wonderful session. It was our privilege to have you today with us. I would also like to thank our national head, Dr. Ruchi Vaishnav, zonal head, Dr. Pooja Kamble, and our all the state team members. I would like to thank our technical team, Dr. Snehal Patel, Uttara ma'am, for a continuous support always. And thanks to our participants to be with us for every webinars. And thank you, sir, for motivating us for explaining which good topic. Thank you so much.
All right, thank you, Dr. Priya and Dr. Snehal and Nirali for introducing. My day was made when I saw Dr. Suvarna logged in. Dr. Suvarna, I don't know if you're listening, but you are a teacher of many of my colleagues. So it was very good to have you here. I think she just logged off. So, okay, thank you so much. Anything I can help me, please let me know. I'm easily accessible on WhatsApp or email. All right.
Yes, thank you, sir. Thank you.
Okay.
Thank you, sir.
All right, enjoy your Sunday.